from Chandigarh of Central IIP. He's a computer whiz kid and he's known as the computer man of IIP. We welcome him. I request, and we also have Dr. Damini. She's senior resident Kalavati Children's Hospital and Lady Harding Medical College in the dermatology department. She'll be answering most of the questions. I request Dr. Pankaj Garg to please say a few words.
Good morning, everybody, and welcome Dr. Tanvi, Dr. Gaurav, for this nice session. Dermatology is something which is very important for all of us. So let us listen to Dr. Tanvi, which is all of us are waiting for. Thank you.
Before that, I once again welcome Dr. Gaurav Rishi Gupta and request him to say a few words. Then we'll start the presentation.
I think it's a lovely, innovative idea from IIP Delhi. And I've always wished to attend these, and I thank Dr. Ajit for, helping me to attend this course. I'm really looking forward to hypopigmented lesions because, we always end up, as general practicing pediatricians, we always end up diagnosing everything as either a fungal infection or dry skin. So I'm sure Dr. Tanvi would be able to guide us better, and hopefully we'll be able to make better choices. Thank you for having me, and all the best.
Hypopigmented lesions can vary from transient and self-limiting lesions to progressive lesions like vitiligo. And to have more clarification, I request Dr. Tanvi Pal to start the presentation. Thank you, Dr. Tanvi.
Thank you, Dr. Ajay. Thank you, Dr. Gaurav. Thank you, Dr. Pankaj. It's a privilege for me to talk about hypopigmented lesions because in my OPD, I see a lot of pediatricians referring, as Dr. Gaurav said, either as a fungal or as a dry skin. So hypopigmented, so it's an overview of a lot of hypopigmented lesions so that it will help us to guide our parents that not everything is vitiligo or not everything is as benign as a dryness. So we'll be talking about an approach to a child with a hypopigmented skin lesions. As we all know, hypopigmentation refers to any form of decreased pigmentation, whereas hypomelanosis refers to specifically decrease in the melanin content. Depigmentation, in contrast to hypopigmentation, in contrast to hypopigmentation, describes the almost total loss of pigmentation resulting in a whitish appearance of the which comes from the underlying dermis. This is a table which basically tells us, it basically categorizes what all we need to know about in early childhood, a localized hypopigmented mark. It can be depigmented, which can be a vitiligo, or congenital syndromes like piebaldism or the partial albinism, Waardenburg syndrome, and the teeth syndrome. In hypopigmented localized lesions in early childhood, either it can be a congenital or an acquired. Congenital can be further divided into nevus animicus, ash leaf macule, and tuberous sclerosis. And then we have hypomelanosis of Ito. So these are few of the congenital, which we normally see in our OPD. And acquired is the post-inflammatory hypopigmentation. So any child with atopic or seborrheic dermatitis can have an post-inflammatory hypopigmentation. So this is very commonly we see in our children, in our young adolescents. So this is like a spotter. So these are depigmented, serrated, multiple lesions on the hand of a child. You can see there are multiple lesions. The dorsum of the hand is also depigmented. So any guesses? It's very difficult for anybody to write. So maybe they can write in the chat box. So this is...
They can write in the question answer.
Vitiligo.
Yeah, vitiligo, yes. So this is the commonest hypo or depigmented lesion which we see and which we are all scared. It's a social stigma in India. And most of the parents who come to us with a white patch they really want to know whether it is a vitiligo or not. So approximately 25% patients have vitiligo before 10 years of age, 50% before 20 years of age. It can be divided into a generalized vitiligo, a segmental vitiligo, or a dermatomal vitiligo. Face is the most common site where it gets affected, followed by the lower limbs, trunk, and upper limbs. Vitiligo is normally diagnosed on a basis of clinical presentation, and there is an important tool for diagnosis, which is we call the Wood's light lamp. Vitiligo being an autoimmune disease, it has various associations with other autoimmune diseases, thyroid disease, Addison's disease, diabetes mellitus type 1, alopecia areata, and pernicious anemia. Normally, as we were talking, vitiligo normally is diagnosed clinically or with the help of Woods light. But to basically rule out any other autoimmune parameters, we should go in for a thyroid profile with thyroid antibodies, fasting blood sugar to rule out any type 1 diabetes, and auto-antibody screen. Woods light examination shows accentuation of the skin lesion. So this is a Woods light lamp, which we all have in our OPD, which helps us. So it has a UVB light, which helps us in basically seeing the vitiligo lesions. So like in this picture, you can see there are these small white patches, which are the mother was concerned. So when we put the Woods light, they became highly accentuated. So it becomes more chalky white. So this is one of the important examination tool which we have for vitiligo, and that helps us to differentiate between vitiligo and other hypopigmented lesions. This is a segmental vitiligo in a young girl, which came to our OPD. Cobrization. So this is a very important entity. It basically tells us about new lesions or new active lesions of vitiligo, which occurs on a normal skin after a trauma or a hurt. So these are so this child had a scratch and that turned into an active vitiligo. There was these burn marks on the child, which actually turned into vitiligo. So this actually signifies that the activity of disease is there, and we have to basically stop the activity of the disease. This was a young case of segmental. You can see there is involvement of the side of the nose, under the eye, cheeks, temporal and the mandibular area. After treatment, he was just left with this patch. Rest was all cleared up. This was a young girl with axial vitiligo around the periorbital area, also treated and left behind with a mild form of vitiligo now. This I wanted to share. This is basically how a pigmentation happens in a vitiligo patch. So you can see the hair follicles. Around the hair follicles, there are these pigmentation, which we call the perifollicular hyperpigmentation or the pigmentation of the vitiligo. So this is one of the ways. So I just wanted to share. So if you see any patch like this, that means the vitiligo patches are getting pigmented. Rather than we say that there is something else, but this is like a the pigmentation in the vitiligo patch. Coming to the treatment, first and foremost, what I tell my patients is basically we have to make the patient comfortable. It's a huge psychological burden in our society of vitiligo. So we have to make the parents understand that it's not a disease which can harm any other system in the body. So it's something like a cosmetic disorder. But because it's such a huge social stigma, we have to treat the patient, but psychologically, mentally, we have to tell the patient that it's not anything big and it's not life-threatening or any of those things. We can start with topical steroids or topical tacrolimus for small localized lesions, so which we normally give twice a day, and we can, after 15-20 days of topical steroids, we can switch to a tacrolimus. A new entity has been introduced in our armamentarium, which is the topical JAK inhibitors or the tofacitinib, which again, so it's a non-steroidal, can be used for longer periods of time, and it is safer in children, so can be done for localized vitiligo. Oral steroids in pulse doses is what we start in active if there are new patches which are coming very frequently. So we start with 0.5 milligram per kg body weight in two consecutive days, and we normally taper the doses over a period of 1 to 3 months. Oral JAK inhibitors are there, but are advised only for more than 12 years of age. That's also a new entity which has come up, so which can be used for steroid sparing agents. Immunomodulators like levamisole has been an old molecule which has been used for mild and moderate vitiligo. Phototherapy is a very good tool, especially for children. It helps us in stabilizing the disease as well as in repigmenting the patches. PUVA for slightly older children, topical sorolanes and PUVA can be used for repigmentation. If the vitiligo becomes stable for more than 2 years, then we can go for surgical methods like punch grafting, autologous melanocyte culture, split thickness, or epidermal blister grafting. As we all know, it's a chronic disease. It takes a lot of time. So, but all we need is patience and more reassurance for the parents. But it's a disease which can be treated. Okay, now this is another patient who had a burn on his face, and anybody, if they can write in the chat box, if anybody can think what it is. So it's an entity called post-inflammatory hypopigmentations. It's commonly seen in association with any eczema or atopic dermatitis or any trauma. So there is a decrease in pigmentation which can result in the disruption of transfer of melanin to the keratinocytes secondary to the inflammatory process or the application of potent topical corticosteroids. Like we have seen, if a child comes with seborrheic dermatitis, a small 3-4-month-old child, so when they heal, they leave behind these white patches, which the parents get very worried about, that what is happening. There was redness before, now there are these white patches. So we just have to reassure the patients that it is because there was a lot of inflammation. So the melanin has not been transferred to the pigment bearing cells, and that's the reason. So we'd only assure the patients and the color comes back. We can also see it in superficial cutaneous infections like childhood viral exanthems, varicella. Post-traumatic hypopigmentation, like in the child which we just saw, is also not uncommon, and it's due to superficial injuries that they sustain. Now, coming to this another entity in which there are these leukoderma patches which are present with the normal to pigmented islands of skin in between. There is this forelock of triangular forelock of white hair which are seen. So this is an entity which we see from birth called piebaldism or the partial albinism. It's an autosomal dominant condition which is present since birth. It favors the ventral surface of the trunk and it spares the dorsal midline. And it usually, there is normally pigmented or hyperpigmented skin lesions as islands within the depigmented patches. And the white forelock is present in 80 to 90% of the children. There is another entity which has this albinism along with the, which is called the Warden syndrome. So there is piebaldism, there is dystopia canthorum, broad nasal root, heterochromia iridis, and congenital deafness. So if a pediatrician comes across a patch which has a child with the leukoderma or vitiligo-like patches, along with forelock of white hair, along with something like heterochromia iridis, a broad nasal root, they should think about these syndromes, because systemically these children, especially the Waardenburg syndrome, systemically there is congenital heart disease, there can be Hirschsprung's disease, myelomeningocele, and facial clefts. So we have to basically work up these child for all these systemic problems. If we see clinically, if we see any of these above things in a child. The treatment, they can be treatments like melanocyte transplantation, Sorolanes or ultra PUVA can be given, sunscreens to basically help in protecting from sun. And like I said, the early detection of deafness and Hirschsprung's will definitely be better for the child and the parents. Okay, it's a very mild, pale, serrated, hypopigmented patch which is present on any part of the body. It is stable. It normally doesn't cross the midline, and which we very commonly see in our OPD patients. So the parent comes with a single patch and say that what it is, and it is present since birth. So what it is called a condition called nevus anemicus, which is a localized vascular anomaly in which the vessels are hypersensitive to catecholamines. Diascopy is when you press a normal glass slide over the lesion, it can be made blend into the surrounding blank skin. It is not accentuated on Wood's lamp, as in contrast with other lesions which have less melanin. It doesn't have a reflex vasodilatory response also. So if you apply pressure or heat or scratch over the nevus anemicus, it will not induce erythema in the lesion, and the contrast can be seen in the surrounding normal skin. We just have to reassure the patient the patch will stay like that. You can say it's just a birthmark, nothing else. It will not grow. It might grow according to the proportion of the size of the baby, but otherwise there will not be any new patches. So it's a condition which we can just reassure the parents and just leave it behind. Tuberous sclerosis or the hypomelanotic patches which we see in a child. So these are the patches which we can see. So these are these macules which you all can see. So if you see something like this, then we have to basically rule out tuberous sclerosis. For that, we need to find out other important clinical and skin manifestation. So these are the forehead plaques which we see in a case of tuberous sclerosis, angiokeratomas, which are these red papules which are present on the malar area, tumors like Conan tumors which are present on the periungual areas, and the shagreen patch, which is a pebbly patch which is present on the lower back. So any of these entities, along with those hypomelanotic patches, we have to think of possibility of tuberous sclerosis and refer to the pediatric neurologist. Okay. This is another entity which we very commonly see in our patients. The child will present with a hypopigmented patch, basically one side a hypopigmented patch, not crossing the midline. So this is what we called nevus depigmentosus or the achromic needle. It's a well-circumcised macule or a patch of a hypopigmentation which is present since birth. It remains stable in size and shape. And in wood slide, the lesion is not chalky white. It doesn't accentuate. It normally is less than 6 centimeters square in size. We don't have to do anything. Again, reassurance to the patient. Just say that it's a birthmark which will heal in. So the parents are more concerned if it's a girl, but we say that it will probably become a little shade darker as the child grows when they are in school and all, but it doesn't show. There is another entity in which we can see these swirls of hypopigmentation. Again, it is one-sided. Again, we have seen this in OPD, and this is called the hypomelanosis of Ito. So basically, these are the blush-coid lines, which where the epidermal migration of the epidermal cells happen. So where there is mutation and these hypopigmentation patches form. So there are hypopigmented peaks can follow Blaschko's line, unilateral or bilateral, present at birth or early infancy. The only thing which we have to rule out is systemic problems in the form of eye, central nervous system, musculoskeletal abnormalities, hair, teeth, which are approximately seen in 2/3 of the patients. Okay, so all these were congenital, or you can say very early infancy or childhood. We see all these lesions. Now coming to the onset in later childhood. Again, which can be divided into depigmented and hypopigmented. So depigmented vitiligo, which we have talked about. Hypopigmented lesions can be post-inflammatory lesions like lichen sclerosus and morphea, and an entity which is a T-cell lymphoma called the Mycosis Fungoides. In post-inflammatory, we have eczema, Pityriasis alba, Pityriasis lichenoides, lichen striatus, post-infection, etc. Let's now do the next. Oh, this is a very common entity which we all see, especially in children who are more of sports person or who are more in sun. They present with these hypopigmented, scaly, round, slightly erythematous, two hypopigmented patches. If you touch the skin, there is a slight difference in the texture of these patches, and mainly on sun-exposed areas. So if I've given clues, so this is what we call Pityriasis alba. So there is a myth that this is deficiencies of vitamin D or deficiencies of calcium. But basically, these are dry patches. It's a minor sign of atopic dermatitis. These children are, so what I tell my parents is that if they're exposed to sun, there is a chance that they can get tanned or hyperpigmented. And these patches, there is a mild eczema on these patches because of the extreme dryness. And these patches don't tan and they leave behind these kind of white scaly patches. So sun exposure, poor hygiene in the form of not putting moisturizers on the regular basis. So again, reassurance, we apply sunscreens, we apply moisturizers. Sometimes if the patch is very persistent, then we can apply a mild topical pimecrolimus or a tacrolimus. There is another new molecule which has come is the PD4 inhibitors, which is the crisaborole, which also can help. So it will be a steroid sparing agent again. So these can be dealt with. So we have to tell the parents again, it is nothing, just plain dryness and nothing else to be done. Okay, this is another entity which we see normally in around age group of 12 to our adolescents till 18 years of age. These are these scaly white hypopigmented patches, which is more or less present all over the trunk. It normally starts with the reddish erythematous scaly dermatitis-like patches, and then they heal into these kind of things. So this is an entity called Pityriasis Lichenoides chronica. It's a benign eruption with lymphocytic infiltrate of the skin. It presents as a persistent erythematous to hypopigmented papular eruptions with scale. Some of the investigators or dermatologists think it represents a hypersensitivity reaction to an infectious agent like the Epstein-Barr virus, the HIV virus, infectious mononucleosis, toxoplasma, adenovirus, parvovirus. It takes a long time for this infection to settle down. We can give mild antibiotics. We can do narrowband UVB for the stopping of further progressing of the disease. Sometimes antibiotics like erythromycin or azithromycin can also help in this entity. If the lesions are very itchy, a mild topical corticosteroid with anti-allergens can also be given. This is another entity which we see in our children. There is this linear pattern of hypopigmentation with sometimes mild itchy lesions on the top. So this is an entity called Lichen Sclerosus. It's a transient lead-in eruption common in children. Follow the lines of Blaschko. It's a self-limiting course with duration varying from few weeks to 2 to 3 years. It can, relapses can occur. We don't exactly know why it happens. There is a chance of post-inflammatory hypopigmentation. Normally, we don't do anything until unless the child is very itchy. We can do a mild corticosteroid to just basically apply for a few weeks so that the itching settles down. But the lesions normally is self-limiting, so it goes on its own. Another entity which we see, so the child comes up with, the mother complains that there is a lot of itching and there is this whiteness which has formed in the areas. It can be vitiligo. Normally vitiligo is not itchy, but there is another entity which we call Lichen Sclerosus et atropicus. How to differentiate it from vitiligo is that they are slightly more whitish, more shiny white, and they are little atrophic. The patches are little atrophic as compared to a vitiligo patch. Vitiligo patch is just discoloration with the normal skin. But in a case of lichen sclerosus, there are shiny white atrophic patches with basically predilection for genital and perianal areas. In the girls, the girl can complain of itching, dysuria, difficulty in defecation. Boys normally presents with phimosis. There is a chance of scarring and a very low chance of squamous cell carcinoma in this condition. So once we see a case like this, we have to treat it immediately. Potent topical steroids, once night application for 4 weeks and then alternate nights is one of the treatment protocol. We can do circumcision in boys who have developed phimosis. So it's basically because of the constant irritation around these areas, which can lead to this kind of a problem. So all fungal, all white patches are fungal, as all normally our pediatric colleagues sometimes say. So this is the first fungal we are talking about. So this is what is called the Pityriasis versicolor. So this is the commonest superficial cutaneous fungal infection characterized by Pityriasporium desquamation, and it can both have hypopigmented as well as hyperpigmented macules. and it's normally located on the chest, back, sometimes on the face. It is caused by the Malassezia furfur fungi. It's more common in hot and humid weather or patients on long-term steroids or immunosuppressed patients. We can do a KOH test. We take little bit scales from the lesion, and we can put 30% KOH and see it under the microscope. We can see a spaghetti meatball appearance. Treatment is topical antifungal shampoo, selenium sulfide, ZPTO, oral fluconazole can be given. There are topical ketoconazole applications are available which the child can use. So normally the children who are playing too much or they're too sweaty tend to have this problem. It's a mild fungus. It's not itchy. Again, treatment is done. Things can be taken care of. Not very commonly seen now leprosy, but yes, this is another hypopigmented lesion which we should know about it, and we should be careful about it, is tuberculoid leprosy. One of few well-defined hypopigmented skin lesions with central sclering, loss of sensation, dry, loss of sweating, hair can be absent or reduced in number, and thickening of peripheral nerve should be felt. So it's leprosy. It's a chronic infectious disease caused by Mycobacterium leprae. The various clinical manifestations are because of variation in the tissue response of the host to the presence of M. leprae. And in children, normally the paucibacillary leprosy predominates. This is another entity which actually is like diagnosis of exclusion. So we have seen something similar in a lot of other pictures we had seen during the presentation. If any of these lesions are still not responding, then ideally one should go for a biopsy of these children. So there is an entity called Mycosis Fungoides. It is a most common type of cutaneous T-cell lymphoma, and it is characterized by epidermotropic T lymphocytes that are clonally expanded in the skin. The hypopigmented variant of mycofungoides is a rare condition, but present commonly in children or adolescents. They are present as scattered, irregular, hypopigmented patches on sun-exposed, non-sun-exposed areas of the body. So non-sun-exposed areas will rule out the P. alba, which is the mild inflammation which we very commonly see. It can also, non-exposed areas also rule out any of the post-inflammatory hypopigmentation patches. So we have to have a high suspicion of the problem. We have to check for internal involvement in the by doing the routine blood test as well as chest X-ray and ultrasound abdomen. Check for lymphadenopathy, and we have to refer to the oncologist for this treatment. So this was basically an overview of what commonly we see, and it will help us to actually diagnose and at least not overtreat the patient or undertreat the patient. If anything which is not clear as a physician, so then we can obviously help or take help from our other colleagues, because as we said, so the spectrum can from a non-treating reassuring skin lesion to a mycosis fungoides, which is a T-cell lymphoma. So the spectrum of hypopigmented lesions is huge. So we just have to make ourselves more aware by looking at various lesions to actually, so it is like what the eye sees, what the mind knows. So it is important that we have to keep looking at the lesion. We can discuss with our pediatric colleagues. We keep doing that in BLK. We keep doing this so that at least we know that we are not missing out anything and we are not over treating anything which we don't need to treat. Thank you.
Thank you, Dr. Tanvi, for a wonderful presentation. It was very lucid. I request Dr. Rishi to please say a few words.
Yeah, I think we have a few questions, and I think it is lovely the way Dr. Tanvi has, correlated all the photographs, images with the diagnosis, and I can already see how many times I've probably missed the diagnosis in all these similar situations. So it's something which I wanted to just add one point, and I think Dr. Tanvi, I wanted your comment on this. There are a lot of situations where kids come to us who have taken strong, potent steroid creams when they come to us for any condition. So what kind of things do we see in that situation? What kind of hypopigmented lesions do we see in that situation? And how can it complicate other cases, for example, a case of a fungal infection?
So, sir, so like I said, so post-inflammatory hypopigmentation can happen secondary to a application of potent corticosteroids for a long time. The thing which you can also see in a child like that will be a very thin skin. So if you touch the skin, you'll see it's slightly thinner as compared to the rest of the area. And there could be sometimes you can see blood vessels going through. So it becomes like, if it is for a longer time, we can see that it's atrophied, and there is blood vessels which has formed over the areas. So that is one thing which is, it's like a very other end of the spectrum. But yes, so what we normally do is, on the face, we normally avoid a corticosteroid, or we give instructions that it has to be used for maybe 5 days, 7 days, because if you tell the patients to use it, they will self-treat themselves, and we have seen striae happening, we have seen atrophy, we have seen paper-like thin skin after use of corticosteroids. So I have stopped unless I know the patient is intelligent and he or she will adhere to what we are saying. Normally, I avoid a corticosteroid on a face, especially, or any, but other areas is still, we can say that you have to use for 10, but you have to keep telling them it is not to be used, not to be used, not to use after that, and switch to something like a pimecrolimus. But yes, like you said, if you're using on a pityriasis versicolor, a steroid, it will only aggravate the problem. Maybe for temporarily, the inflammation might go down because it's an anti-inflammatory property of a steroid. But once you stop the application, it will just all flare back. So,
And
Dr.
yeah,
just to
add, sir, just to add, what happens if the commonly used, the quadri combinations which have everything are used in these situations, or even a combination of a steroid with antifungal is used in these situations, like tinea versicolor, or some of the other formulations which have everything in them, antibiotic, antifungal, and everything.
That is like a Ramban. So something will work. So it is something like that. It will work with. But the only thing is that, yes, it will work maybe temporarily, because obviously it has an antifungal and it has an anti-inflammatory. But once you stop the thing, it will just all come back, and it will all come back in a big boom, not like a mild lesion or something. And it will be very difficult for us to treat, because it becomes a modified picture. We are not able to exactly see what was there earlier, and after the modification by the topical steroid, the picture changes and it becomes. So now what we are seeing as a pediatrician is, we are not seeing regular fungal cases. We are only seeing these modified pictures, and we have to actually go back and say, okay, it might have started like this and now it is modified thanks to the steroid. We have to.
Thank you, Dr. Tanvi.
Request you to please stop sharing the screen. Stop sharing the screen.
1 minute, sir.
Thank you. Dr. Gaurav, please go ahead. You were asking something?
Yeah. So I think that is the important point which I was just trying to highlight, that as a pediatric dermatologist, you would probably be seeing all kinds of complicated cases which have been complicated by first GPs and then somehow to some extent by pediatricians as well. So thanks for telling us that.
So it's not. Yes, sir. Sorry.
You said vitiligo is the commonest lesion that you see. Maybe as dermatologist, you see the vitiligo as the commonest lesion. But in pediatric practice, I think Pityriasis alba is the commonest lesion we see in the OPD.
Yes.
Yeah, Pityriasis is like the commonest. It's like they'll come up with calcium khana hai, vitamin D khana hai, doodh nahi pee rahe. Matlab, these are all the common myths which we see. Yes. P. alba, yeah. In the sense, vitiligo is one of the. So problem is, the patients or the parents are more worried about vitiligo as a hypopigmented lesion. So they would just want to rule out that it is not vitiligo, and anything else.
Their main concern is it's not vitiligo.
Yeah, it's not vitiligo. Well, I have parents who are like, so birthmark, so which some birthmarks don't come up exactly because the color of the child is lighter or whatever. So when they no, it is not, it can't be a birthmark because it was not there at birth. So we have to reassure again and again that it is not vitiligo. Just leave them, just leave it alone. It's such a big social stigma in our country. Sometimes we don't want to treat it also, but can't help it. We have to treat the lesions.
Dr. Pankaj, please go ahead.
Yeah, Dr. Tanvi, as a pediatrician, do you think that we should have a wood slide at our place? is it something worth for our OPD practice? Because we also see a lot of patients which are hypopigmented lesion. We are sure that it's not vitiligo, but they still want a confirmation and they want a
So
referral.
you can, it's not a very expensive, it's within 1,000, well, it's I think 800 or 900 rupees Woods lamp. It is present. Derma India is one company which gives it. It's present online. There is no harm in keeping it. At least you can rule out and at least give a reassurance to the parent. See, if it is vitiligo, then definitely we need
Then
to
it
treat.
needs a referral. Yeah, definitely it needs. So thank you for that. So it's I think as a good pediatric practice, if we have it with us, it helps. So
Yeah, Dr.
we should
Arya
have it.
always used to say that I want to procure and keep it in my practice, Dr. Subhash Arya.
Yeah. The other
Dr.
is that
Tanvi,
about
please
about
go ahead.
pediatric versicolor. He said that use of ketoconazole, which helps. So I've seen that the availability of ketoconazole 1% versus 2% always remains an issue. So which one you recommend and for how many days?
So see, like we can do an oral fluconazole, which is one single dose, and that helps it. So the infection goes 1% ketoconazole, KZ lotion, one of the brand names are there, that is 1%, which we can ask the patient to apply. Normally, what I do is for 2 weeks to 2.5 weeks, I normally ask the patients to application. The hypopigmentation takes a longer time to go. The infection settles down. The infection goes within 2 weeks to 3 weeks. For hypopigmentation, because the mother will come up and say the abhi bhi white hai. So what entry we have asked the parents to ask the children to sit in the sun a little bit, and they can put UD-colon. So the UD-colon which you guys use on the face post shaving can help in repigmentation. So we just apply UD-colon on the back and ask the parents to expose the child to little sun, and that helps in repigmentation faster. So the problem of infection is not long. It within a single dose of fluconazole in older children, an application of 1% KZ ketoconazole lotion, that will within 2 weeks the infection, they are infection free. But the issue is just the hypopigmentation, which takes a little longer to go.
Thank you so
Dr.
much.
Tanvi, can you name a few good sunscreen lotions, because many parents they ask for it.
The brand name, brand
हाँ
name
बता दीजिए.
सर L-Free is Curioso जो अब torrent हो गया है, so उनका एक L-Free करके sunscreen है, which is a nice sunscreen. Any sunscreen which is a physical blocker, which has zinc oxide mainly, can be used for children. So La Shield has a Physico gel, which is plain in the sense zinc oxide, so which can be used. There are little expensive. Semamed has a children's sunscreen, but that's slightly on the expensive side. Solar D is another company which has a kids sunscreen. So these are few of the brands.
We welcome Dr. Alok Bhandari, President IIP Delhi. I request Dr. Alok Bhandari sir to please say.
Hello, sir. How are you?
Fine. Good morning, ji. It's always nice to listen to Dr. Tanvi in the morning. So it's a great morning. I can say that we have made our morning by listening to Tanvi on a very, very relevant topic. I am sure more than all the delegates who have logged in will be wiser by listening to all this. And our guest speaker, Dr. Chairperson, and Dr. Gaurav. Gaurav is here, sir. Gaurav Gupta ji, Chandigarh, Mohali wale.
Sir, अभी तो थे. I think he just logged.
नहीं सर यही हूँ बिल्कुल यही हूँ.
हाँ है सर.
म्यूट पे था. बिल्कुल यही हूँ. Good to see you.
आपके लास्ट सेशन में अटेंडेंस कम थी तो हमने कहा आज कॉम्पेंसेट कर देते हैं. Now you have a large audience and Gaurav is a multi-talented personality. He's got pediatrics, तो इनका एक मतलब just 10% of his personality है. He's an excellent pediatrician. But otherwise also, and I welcome Dr. Gaurav also. आपसे interaction अभी फिर थोड़ी देर में करूँगा. And
definitely.
I think, what are your comments on the session today?
Very, very, very interesting. I really loved it. मैंने Dr. Tanvi का थोड़ा सा brain, I already picked the brain about a couple of points जो हमारे OPD practice में होते हैं, because मैंने यही बोला उनको कि with all the slides that you have shown, I can now confidently say मैंने बहुत सारे patient misdiagnosed किए हैं already in my practice. So definitely a very good learning experience, and I think the entire module is a wonderful idea. आप लोगों का having 14 sessions on pediatric dermatology is really, really needed, and I really enjoyed it. Thank you for having me.
Ajay, please
Uh,
continue. Ajay.
Dr. Tanvi, do we really need to treat post-inflammatory hypopigmentation or it will go away on its own?
No, sir. Just reassurance. We tell the parents that it is like when you get hurt, the lesions heals with the hypopigmentation and then the color comes back. So it's just wait and watch. If they really want, they can put a little coconut oil for just like
Maybe
healing the
good
skin.
moisturizer or something.
That's it. Nothing else. We don't need anything.
Because giving steroid will again just
No.
do
No steroid.
trophy.
Nothing. Just reassurance and maybe just to help them in the sense just a moisturizer or a coconut. I normally say coconut oil. That is again like a best thing.
Can you, because Pityriasis alba is very common condition in our OPD, pediatric OPD. Can you once again, because some of the delegates are also asking, Dr. Damani has already answered, but still I would like to hear from you. Do we need to give tacrolimus or should we, in that case, refer to...
Sometimes some patients do need tacrolimus if there is a lot of inflammation or like a scaling. So if it is the patch is very, very dry, so there is a mild subacute underlying eczema which is there. So which generally don't get only cleared up with a moisturizer or a sunscreen. So for those lesions, something like a pimecrolimus or a tacrolimus can be given just for few weeks. So it helps in reducing the inflammation faster, and then it'll help in repigmenting faster. So those cases, otherwise
We
not.
start with just moisturizer and continue for a few weeks, and then if required,
If
go
it's
for
required, then we can.
steroids.
Sometimes, yeah, if
Hydrocortisone will be good enough, or Desonide will be good enough.
hydrocortisone, sir, again the problem comes up that if they use it for too long, then there can be a chance of hypopigmentation again. So then it becomes very difficult for us to differentiate. So normally what I do is a pimecrolimus for some time. Until unless the child is very scratchy or itchy, then we can think of a mild steroid like hydrocortisone.
In a OPD child coming to a pediatrician, just advise moisturizer or anything else?
Moisturizer and if he or she plays too much in sun. So sir, we have to prevent the tanning because it becomes because of the tanning, it becomes more evident, these lesions. So if the rest of the face is sun protected, so at least that will not tan further, and the difference between the patches and the rest of the skin will become lesser.
In which condition we need to refer a child with hypopigmented patch to a dermatologist?
Sir, if you suppose like a Pityriasis alba only, and if you have treated for few weeks with moisturizer or with pimecrolimus also, and if still the patch is not going, then we have to rethink that maybe something else we are dealing with. It could be a vitiligo, which probably started with a eczematous area, but it has turned into a vitiligo patch. So these are few of the conditions, or uh, lesions like full body patches which are available, which comes up, not the congenital one, but later onset. So like PLC and all, which actually, when you see, you'll say, ki, okay, this is probably not dryness or anything, which you will probably think it is more than a dryness. So these are the areas where you can refer to us.
Legs. Yes. Sometimes multiple hypopigmented lesions on legs children commonly see. What these are most likely following some injury or post-inflammatory hypopigmentation. Most of the questions, sunscreen, clotrimazole. Can we use clotrimazole cream instead of ketoconazole for tinea versicolor?
Clotrimazole doesn't work on the Malassezia furfur fungi. So it's basically the azole group is more.
Better to use oral fluconazole and...
Yeah, sir, in adult in the sense 12 years and above, we can do a single dose of fluconazole, which actually works. We don't have to do much.
So we had a session on atopic dermatitis where we discussed about the moisturizers. Can you just name one moisturizer, good moisturizer that you use for the children?
Cetaphil is a good brand. It's a tried and tested over 50 years. Cetaphil moisturizing lotion or cream is good.
That's good. So, Dr. Damni, are there any more questions which need to be answered?
No, sir, I think I had answered most of the questions.
Thank you so much. I request Dr. Alok Bhandari sir to please say a few closing remarks. Dr. Pankaj, you want to say something? Your hand is raised.
I had a question, Dr. Tanvi, in case nobody is asking anything.
Dr. Gaurav, you want to ask something?
Yeah, Gaurav, go ahead, please.
Yeah, please go ahead.
I was just interested in knowing about vitamin D vis-a-vis sunscreens. I mean, does the use of sunscreen reduce vitamin D production in children? Any ideas about that? That was a question that I had.
So, see, anyways, the sun which is coming to us is through these pollution and everything. So, anyways, the sun is not actually doing vitamin D production for us. So, ideally speaking, oral vitamin D, like we have now started giving every child once a month or once in 2 months, whatever the protocol is. Tanning, yes, it happens. So there are parents who the children are playing sports, they are in the sun too much. So obviously they're all conscious about their skin color. So we haven't seen much. So, and only face application doesn't much. The rest of the body is, if it's exposed, we can have, if vitamin D is happening, getting made because of the sun. So then rest of the body is anyways exposed. So only the face doesn't make much of a difference.
And any nutritional deficiencies that may be associated with hypopigmentation?
That is commonly the parents ask, calcium kam hai, vitamin D kam hai, ya kuch kam.
Typical.
This is the myth which everybody has. No, sir, aise kuch nahi.
Dr. Tanvi, one more thing. How do we differentiate photosensitivity? What happens there will be only erythematous lesions or hypopigmented lesions also?
No, sir, to start with, there will be erythematous lesions. And maybe once it clears up or when it gets better, then it can lead to a hypopigmentation. But to start with, it will be very itchy and reddish lesions if it is photosensitive. Child is photosensitive.
Thank you. So if there are no more questions, I request Dr. Alok Bhandari sir to please say a few words as closing.
Well, Ajay, after a very good dermatology, now I think we should also take our academics and advocacy go hand in hand, and we should take our responsibility of association strengthening also along with it. And I'll utilize this opportunity that as president of Delhi IAP, I will request all the pediatricians sitting in this logged into our class today, just ensure all those who became associate life members during their post-graduation, they should send their degree copy to the central IAP and they should convert their membership from associate to full life membership.